Welcome to the Becoming Ronin podcast.
Becoming the person you most want to become.
Well, we have your books right here.
I
just
see that.
as
Yeah.
I'd like to point out that mine is much more well worn.
Well,
Smitty's looks brand new.
Yeah.
So
Right.
Yes.
Well, he doesn't care about the neck or the knee or
Exactly.
the foot. Yeah.
the plumber's pipes are always leaking, though.
That's right.
That's
There
the
we
guy
go.
who needs it.
Wow. Well, we're starting off the podcast right with insults moving
Yes.
in that
Mhm.
direction.
There you go.
We are recording, Shirley, and this is very
Yeah.
conversational, so it doesn't have to be, as formal or whatever. But I did want to just start letting you know we're in the strength conditioning world,
Yes.
and fitness is sort of our knowledge base, but in that pursuit, we have utilized a lot of your ideas, and again, we're very honored that you're with us today. I did wanted to ask you, there is this, I'm always seeking this balance of how strong is too strong. And
That was going to be one of my questions to you.
well,
He hasn't figured that out.
that's right. But heard you talk in some of your lectures about the role of hypertrophy and stiffness. And you did make mention of sarcomeres and parallel and how that's sort of the foundation for building hypertrophy and muscle mass. But there is sort of this other side of it, possibly to our detriment, of stiffness entering the body. And it's something that I've actually talked a lot about because I'm 52 and I've seen sort of my idea of programming for a lifetime shift as I've gotten older, because in the beginning, I was always pushing heavier and heavier weights. And as I've gotten older, this idea of longevity and maybe training for a lifetime has been more of my focus. So how do I train smarter for longer? And one of the things I always say is tension into the body makes it stiffer, right? We're using these weights, these external weights, to create muscle hypertrophy. But at the very thing that we want to do is become more fit, but our strength training is making us move worse, if that makes sense. And I was wondering if you could just talk about how this idea of stiffness is it comes from the strength conditioning world, but it's really sacrificing our movement quality.
Yeah. I mean, like all things, there's good and bad. And just like you're saying, it's good to be strong, but too strong is bad and too weak is bad. So it's finding that middle road. And stiffness is one of those things. Now, when you hypertrophy a muscle, it does get stiffer. And when I'm talking about stiffness, I'm talking about the passive tension of muscles. And the passive tension really comes from a number of factors that they haven't worked out but completely. But in some ways, it's the epimysium, perimysium, and in other words, the collagen that separates muscles into bundles is one part of it. If you look in a muscle cell itself, it's a large protein, a very large protein called titin. So I'm specifically talking about the passive tension of muscle when I talk about stiffness. Now, there is literature about combining the passive tension with the active tension and calling that stiffness. But the reason why I'm so keen about using the term stiffness or passive tension is that in the physical therapy world, muscles were often labeled as short. And what I found out, because I had a whole lot of years that I wasn't doing anything else, is that if you passively move, let me give you a specific example. If you have someone lying prone and you passively flex their knee and their pelvis tilts anteriorly, the dogma was the rectus femoris is short. Well, that wasn't hard to disprove, because if you prevented the pelvic tilt, the knee went through the full range. If it was short, it shouldn't go through the full range.
Mm-hmm.
The other factor in observation was that tilt came on long before you got to the end of the muscle length. So if it was a muscle length problem, it shouldn't happen before you got to the end of the muscle length. So the whole idea then is this is the stiffness of the muscle, the passive tension that causing, I'd like to say, the tail to wag the dog. And the reason why that's so important is stretching the rectus femoris will do nothing. That the treatment is to stiffen what gives so that that stiffer muscle doesn't cause it to give. And in the situation I'm talking about, it's like the abdominal muscles, and particularly the external obliques that need to be stiffer to prevent the anterior tilt. And the other reason why it's so important is that motion is what's going to cause back pain. If you had somebody that had a short rectus femoris, in fact, it's really not rectus femoris, most often it's the tensor fascial lata, but anyway, if you had a short rectus femoris and somebody bends their knee and it stops at 90 degrees and there's no pelvic tilt, that's not nearly as problematic because it's not making the back move.
Mm.
So that's stiffness. Now, so in some ways, it's used, or it should be used as a criteria, an indicator of the many factors that are making that pelvis anteriorly tilt. So that same person that I just described, if they stand up, it's probably that their pelvis is in an anterior tilt and that the hip flexors, even in standing, are stiffer than the abdominals. So even in standing, the lumbar spines are being pulled into extension.
Wow.
If they're lying supine and they go to move their leg and they slide it down, that just stretch, little tension on the hip flexors will cause the pelvis to anteriorly tilt. So you're wearing the back out by constant moving, by having this imbalance in the stiffness of muscles that are basically antagonists.
So one of the things that we talk about, actually, I think it was the last episode we recorded, we were talking through some laws of corrective exercise. And one of them that we came to was something along the lines of whatever's tight, focus on pumping the antagonist. And we said pump partially because, you know, being in the strength and conditioning world.
You don't know how to hypertrophy.
Yeah, exactly. And part of it though, like, you know, one of the things that we borrow from the bodybuilders is intention, and they're really good at contracting a muscle under their own volition. And we find that in corrective exercise, we do a lot of post rehab in our facilities, and it's almost impossible to train a muscle if you can't connect to it. So is there any part of that, if it's just a stiffness issue and it just needs some more stiffness? What's that?
Is it just
yeah, not to downplay.
Issue? Okay, well,
I guess where I'm thinking about the stiffness is like that. If that's the true problem, then the dynamic motor control is less of a factor. Am I understanding that correctly?
No, because, you know, too often people think of motor control as something where you're sitting up at the top of your nervous system and sending down messages. And the facts of the case are activation patterns are an interaction between muscle and the nervous system. So the more you have, like the example I'm giving you, like the hip flexors that are hypertrophied, the more readily they're going to be recruited by the nervous system. I'll give you another example that's very concrete. And this also talks about the bad side. So, you know, coring the core is such a big deal these days. And when I was at the end of my work career, sort of, I saw more patients that had too much abdominal hypertrophy than not enough. And they got what I called the squeeze-o-smash-o effect. Because, again, there's so much passive tension from those abdominals being hypertrophied that it increased the compression on the back. And if you had a slight asymmetry, so the back was slightly curved, you had real back pain because of this effect. Now, when people hypertrophy their abdominals too much, they get a thoracic kyphosis. Do you know what I mean? An increase in the thoracic curve. And then what do? They sway back. When they sway back, their abdominal muscles become their anti-gravity muscle. So now, if they wanted to pick up an object, they would sway back and pick it up using their abdominals rather than use their back extensors. So you're building in a bias to the activation pattern by the hypertrophy. They aren't separate. The brain doesn't just stand up there and say, oh, I think I'll choose this, or I think I'll choose that. It's tied in. The body wants to be efficient. And that efficiency says, I'll use the things I use most often and let the other things just kind of rest. And that's why you get this imbalance between what's hypertrophied and what gets weak. Because to me, the really interesting question is, why do normally innervated muscles get weak? I mean, in days of old, of polio or trauma, you can understand muscles got weak because they were injured. But we're now talking about muscles that are not injured, but they get weak. And the weakness is because of this interplay of recruiting what works best and bypassing what doesn't work best. And that's why it becomes problematic.
So basically,
have I made any clarity to that at all?
I think so. Well, I'm about to find out if it makes sense to me.
Here we go.
So the hypertrophy is the foundation for creating movement through the path of least resistance. And then that becomes the preferred pattern.
It's one of the factors, like the one I was describing, very good path of least resistance. In the example I was citing to you, the path of least resistance would be lumbar extension. Hypertrophy and stiffness is on the side of the hip flexors. The counterbalancing abdominals aren't doing their thing.
I see.
Or you could say with the thoracic kyphosis thing, that the thoracic back extensors are not, they're not stiff enough to prevent the thoracic kyphosis. So it's this balance between. That's why looking at alignment, I mean, this is another really interesting thing to me, is that when you look at somebody's alignment, the body, again, has these rules. It wants to minimize energy expenditure. And so it's going to have you stand in ways that minimize your activities, your muscle activity. And that's where the passive tension again comes in. So it's going to use, and you know, in fact, I was guilty for too long thinking about that the only muscle that had passive tension was the hamstrings, because you pull the knee out or you do a straight leg raise and you say, oh, feel that. But I never thought about how much all the other muscles had passive tension. And what's great about it is it increases your efficiency by minimizing your energy expenditure. What's bad about it is that it leads to musculoskeletal problems, unless you're very, very adept at making sure that that person is working all the muscles optimally and nothing too much, like you started all this with. And don't use the word tightness, because it doesn't mean anything. Yeah.
So is this like kind of what McGill, sorry, Samantha, I know you have the question, but is this kind of what McGill would call elastic equilibrium?
Yes. I hadn't heard you using that term, but that's good. He's learning things.
Maybe he got that from you. Maybe.
I think he did, but not the term.
Yeah. Okay. Gotcha.
Now we have great respect for one another. So
awesome. I'm sure.
Yeah.
So,
we do.
Yes. So I was just wondering, what is your strategy? You mentioned posture. Do you integrate a lot of Yanda's upper and lower cross syndrome as?
No, it's just too vague and crazy. You know, I like practical things, and I don't. What he talks about as syndromes is too far afield. It's what I'm talking about here is the details of anatomy and kinesiology. And to use vague terms that don't mean anything is just leading you down a garden path. I mean, Yanda also said that if you have these problems, you're a mini cerebral palsy. Well, that's, that's ridiculous. All you have to do is be participating in a sport and not correcting what the sport does. And that's usually not cerebral palsy. So I don't think of it in terms of these syndromes one way or another. I think of hip flexors are too stiff, abdominals are too weak, et cetera, et cetera.
But do you use posture as sort of your starting point? You mentioned like anterior tilt and maybe the elongation of the abs. And
well, the point I'm trying to make to you is when you look at somebody's alignment, you have a big clue as to what's stiffer than something else. It's your guideline for what needs to be corrected. I was thinking about what you might want to discuss, and I think I don't know what you all do, but when I look on the internet, there's too much of one that one exercise fits all. Well, that's just totally naive. It's ridiculous. The kind of abdominal exercises that I see promoted on the internet. I mean, they're all doing the same thing. They're trying to curl their body and hold their legs up. Well, if you want to get really short hip flexors and a kyphosis, have at it. So one size does not fit all. People aren't all the same. You probably noticed you're taller and he's shorter. That
Yep,
makes a big
very
difference.
very much.
You know, how wide are your shoulders? Because men that are wide and walk like this, they get weak hip abductors because they're unloading the hip abductor. So if you're short and you get up from a chair, you have to use your quadriceps less than if you're tall and your knees are higher than your hips. Then you've got to use them more. So all of these individual differences bias what's selected, but you get a good clue to that when you look at what their posture is.
So to piggyback off of your question, if you're performing an assessment, now kind of switching gears a little bit, obviously there is carryover with athletes that have pain, but let's say someone is coming to you for pain. And if we could use that low back example of maybe an athlete with low back pain, so their abs are over stiff.
Yep.
And, you know, one of the things that we've talked even about on this podcast is the movement impairment syndromes. And I love how they're simple to understand because whatever causes pain is the syndrome. And so I guess my
I wish
question,
you were a physical therapist.
well, listen, this is a book that a lot more strength and conditioning personnel need.
Let me just tell you, this material is more popular among strength and conditioning people than physical therapists. That's
interesting.
What's tragic.
Why do you think that is?
I think there are two reasons. Number one, in physical therapy, this is a criticism of my own profession, but I can do that because I was practically there when they developed it, is that the big focus is on knowing treatment techniques. So you have different schools of thought, you know, the McKinsey technique, the Maitland manipulation, etc. So the focus is on treatment techniques. And I think that the strength and conditioning people have learned that making somebody stronger doesn't change the way they move. Then you have to change the way they move, and then you can make them stronger. And I think you all have done better with that than the physical therapy community that just wants to know, what tool do I have in my toolbox? And there's less and less figuring out of what do you need those tools for.
Wow.
Yeah.
I personally, the thing that I've gathered too, I don't know if this is true, but it seems like most strength and conditioning personnel are in the private sector, and you have to be able to withstand the consumer, you know, and people that are coming are private pay. So if you're not making any progress, they're not going to continue to pay. And it seems like there's, I don't know what you call it, maybe failing up in the PT world where they can afford to not make any progress with their patients. And
it's
still
another thing. It's called push for productivity. Yes. And then people have contracts, and you've got to go to this physical therapy service, whether they're good or not. That's one of the demises of private practice in the profession. Because as you say, you went to a private practice because they had a good reputation and they did a good job and they took time for an exam. And that's one of our other problems. We don't have a standardized examination. And that's tragic. It's tragic.
Yeah, that's kind of leading me back to my question about this is like, you kind of touched on it a little bit about how strength and conditioning specialists tend to understand that movement must be contributing to the at least the mechanism of injury. And my question, I guess, I'll leave it a little more open-ended, is what would that assessment look like? And if you were to maybe standardize some assessment,
I have a very systematic standardized examination.
Could you elaborate on what that would look like if one of us came to you and we were an athlete and we had low back pain and some of the things that you just touched on?
Well, just as I said to you before, is I'd be looking at your alignment. Are you in an anterior pelvic tilt? Now, many men have what we call a tall pelvis. So, before the belt line got to the level of the greater trochanters, under the underwear or something, if the top of the pelvis was at least an inch or so above the belt line, that's a tall pelvis. And what goes with that is usually a flat sacrum and a flat lumbar spine. There's no curve. So if I see somebody with that, and then I'm going to think it's a lumbar flexion problem as compared to a lumbar extension problem. If they've hypertrophied their abdominals, it's even more so because that holds them in flexion as well as keeping. And when you have a flat, it's just like with forward bending then. The first 30 degrees are to reverse a curve. So your spine doesn't go flat, ideally, for 30 degrees.
Okay.
If you got a flat back to begin with, if you flex 50 degrees, you better call 911 because you have gone much too far. So what does the person present like that's going to lead me to either support or dissupport my thing? If they have more pain sitting than standing, it's going to be lumbar flexion. If they're more comfortable sitting than standing, then it's probably going to be extension. So you have these patterns. To me, that's what's so important about having a diagnosis and a systematic exam, because you have pattern recognition. That's how physicians work. I mean, they don't understand most mechanisms, but they have these criteria that says this is going to give you heart disease, this is going to give you diabetes, et cetera, et cetera. Okay. So I look at their alignment, get some idea of what it might be, and also always relating the symptoms to what's going on. I don't spend a whole lot of time on it because it's a waste of time. But I mean, to get a big, long history, that it's kind of like, I don't trust people. So then I have them do forward bending. Does that hurt? When? On the way down? On the way back? Are they getting excessive lumbar motion? Are they barely able to reverse the curve? Okay. And then I change it. Let's say they get pain going down. Well, then I have them practice flexing their hips rather than their lumbar spine. If the pain goes away, chalk up a supporting factor for lumbar flexion. If they get the pain on the way back up, I have them change it so they do more hip extension and less lumbar extension. If that modifies their symptoms, that's it. And then I have them do side bending, because if it hurts going to the side, they've got a rotation component. If it hurts going to the side, then I put my hand just above the iliac crest, hold them still there, have them side bend again, and often it doesn't hurt. And that tells me that that movement down there is what's causing the pain. I mean, it's like so simple, you can hardly believe it. Then I have them do rotation, because one of the things that's really interesting, it's like, for me, it was like too soon old and too late smart, is that, and to me, it ought to be particularly important to you guys and also to the world of sports, is that I think I had assumed, I don't know that other people didn't assume, that when you looked at how much a hip rotated, okay, are you with me?
Yep, I'm following you.
That when you were standing and you rotated your pelvis, that you would have at least a good percent of that motion from the pelvis sitting
with the foot
on the
planted.
femur.
Right.
No, you don't. In some cases, you have none. So if that pelvis and femur are moving together, that's how you get knee pain, because it's got to give somewhere. Or that's how you get a flat foot. Better the foot than the knee.
Right.
And the more you hypertrophy the muscles about the hip, the stiffer they are, and the less motion you're going to get of the acetabulum on the head of the femur. So now I watch, before I just watch what their back did, now I watch what their pelvis does. And what you'll often see is that in people that throw things, is that they'll go farther to the side where the pelvis doesn't move, because they can't move there. But that's what's playing into their back pain. So they're twisting instead of rotating.
Wow, that's a great point about the pelvis doesn't rotate the same when their foot's on the ground. I mean, if you think about every golfer ever.
I know. Well, why do you think, Tiger Woods and all the others started out with a bad knee?
Yeah. Wow.
That's why.
That's incredible.
Yeah.
So what? Well, I'll let you continue there.
Okay.
Yeah.
So that's what I do in standing, and then I supine. I like to do what's called the hip flexor length test. We've changed these names a little bit. I call it hip extension with the knee. So somebody's sitting on the edge of the table, and I lower the leg down.
Okay.
And I've got to be sure you have the weight of the leg, but I'm lowering it down because I want to see, does that pelvis tilt? I want to see, does the leg stay in the air? Does it go out to the side? I can tell you most often the problems with the tensor fasciae lata, iliotibial band, that more so than the iliopsoas. That's almost rare.
Wow.
And then if there's any asymmetry between one side and the other, sometimes they get symptoms And then you prevent the pelvis from tilting and seeing if that reduces the symptoms. But that gives me a clue, again, on how any asymmetry or how much the lower extremities pulling on the spine. And then I put them supine. And then the next thing, and this is another important thing for you fellows to be aware of. Do you know what femoral retroversion is, or femoral antiversion?
Yeah, but if you could elaborate,
I
it's
will,
basically
because,
the angle of the neck.
yeah,
Is
but
that
do you know
right?
why that's important?
So you're testing the actual boundaries of the joint rather than their anatomy?
Well, you're testing their anatomy, which is the actual boundaries of the joint. In other words,
That makes
most
sense.
men have femoral retroversion. This is
Ah,
another reason why the golfers get into trouble. If they put their feet straight ahead, they're at the end of their medial rotation range, and it's going to give somewhere else, their back or
wow.
their knee. So, and that's, I've had patients, even physical therapists, who did deadlifts. I keep wondering why they're called deadlifts. Is that supposed to be the outcome or what? But anyway,
Sometimes.
I think so. I know. What's often dead is the lumbar spine after that. But anyway,
The
um,
disc.
yeah, I know. Anyway, I think Stuart is also in my corner about too much is too much on lifting. But anyway, so the instruction is when you do deadlifts, have your feet pointing straight ahead. Well, that's a mistake if you have femoral retroversion. So my word to the wise is when somebody's lying supine and you just passively roll their leg in and out, if they have a whole lot of out and no in, they've got femoral retroversion. Women had, it seems to be changing now for some reason I don't understand, women had much more antiversion. So they have a lot more in and very little out.
Yeah.
All of that should be built into how they do things. Because if they're at the end of their range, then they're going to get these problems, as I say, in the back or the knee, something like that. Okay, so I want to know that. So I do that. And then the next thing is, in fact, it has the orthopedic surgeons call that the log roll. And I don't know what they're doing it for. But anyway. And then I do passive hip and knee flexion. And the reason why I want to do that is because, number one, I want to know how heavy is the leg and how stiff is it and how well can they relax. Because one of the other downsides for many people when they do, like I've had young girls who weigh 125 pounds that are lifting 250. Now, that to me is inviting disaster. It's too stupid. That's why we have machines. The patients are getting that big, but don't lift them, So what they can't do is relax their legs. They're so stiff, and it lowers this threshold of activation. So I want to know, is it stiff? Is it heavy? Because muscle weighs a lot. Because it doesn't get any lighter when it's their turn to move it. That took a while to figure out, too. And if it's stiffer, then they really have to work hard. So they become their own resistance machine. Then the other thing you want to know in this day and age is, do you know what FAI is?
Yeah. Impingement.
Yeah. Do you know?
Femoral acetabulum.
And do you know what it's about?
Is it like the pincer cam deformity, or are you going that route?
Yeah, the cam is, you can get pincer too. Cam is more restrictive in range. In some ways, not as much. I mean, pincer's bad too because you're hitting on the edge of the acetabulum. But what it means is the hip can't flex in most cases, more than 95 or 100 degrees.
Right.
And one of the things I and my colleagues are trying to do is to get away from the term normal. Because normal is the average of a lot of variations. And to think that everybody should have 125 degrees of hip flexion is like saying everybody should be 5'4", but we don't cut off the legs that are 5'6" and put them on those that are 5'2". It's like you've got to take into account these structural variations, like the version, like the limited hip flexion. And the more you try to do it, the worse you're going to create a problem. I mean, that's going to be the cause of injury. Just like in the squat, if they can't go more than 95 degrees, they can't squat down.
Right. Yeah.
I mean, and if your shoulders are a lot bigger than your hips, you're going to have to use another strategy. And if you have a high instep and you can't dorsiflex, you're going to have to use another strategy. So all these individual variations play a role in what's playing.
Wow.
Okay, so passive hip and knee flexion, and then I'll have them do it actively. And does that cause symptoms? Does the pelvis move? Whatever. If it causes symptoms, I hold the pelvis still to see if that gets rid of the symptoms, because again, it's in that feature of the tail is wagging the dog. And then I also like to do with one hip, and I do it. If somebody comes in acute pain, probably the most pain-free position is what we call hook lying. So hips and knees are flexed, and it may be necessary to put a pillow under their knees so they're not tightening their muscles at all, because tightening them will give them symptoms. So then you have to just slide one leg down and see how far they can go while being relaxed. But you probably don't see too many people that are acute. Probably these more chronic problems.
Yeah.
Okay. So then, the other one is, again, from hook lying, hip and knee flexed. I let the leg go out to the side. People call it bent knee fallouts. And the reason why I want to know that is I want to see if the pelvis rotates with the leg. Not at the very end of the range, but early in the range. Because again, that's another indication that the abdominals are not preventing rotation of the pelvis. And this is where people get so misled. The Australians have been able to build up the role of the transversus. I always said they did that because they're both down under. And the transversus is not going to stop the rotation. It can't. It's not built that way. And it's good to have if you want a skinny waist, but it's not going to keep your pelvis still. So I'm doing it to see if the abdominals, because that's the interaction of both the external and the internal obliques, are providing adequate support. And then, and this is going to get to your other question. And everything is, if it hurts, you change it so that it doesn't hurt. And to me, the really big advantage of all that is you're teaching the patient to be in charge of their problem. Because you're saying, if you move this way, guess what? It hurts you. If you change it this way, guess what? It doesn't hurt you. And you want to get rid of pain in the brain. That's the most important thing, is putting somebody in charge of it. Rather than, I don't know what I did. I can't do this. I can't do that. That's the big advantage. So then they go on their side. I want to know if that hurts. It's going to be more women than men because we have a nice wide pelvis and very small waist. We wish. Anyway, and that's another thing that's important, because you've got people that are apples and you've got people that are pears. And the apples aren't going to have as much trouble as the pears, because the pears have a much wider pelvis than the apples. Apples will have a trouble with getting a flat trunk, because that's where they put their fat, is in their abdomen. Right. In pears, one, they probably have femoral coxa, and number two, that's where they put on their weight, is in the lower, around the hips. So if it hurts when they roll, we practice rolling. And if it hurts while they're on their side, you put a little towel or pillow at their waist so that they're not in a side bend. But all of this is telling you how acute the problem is and the motions, because if that's the case, again, rotation is part of the component. And then I have them do from, again, the Australians were able to do this. Oh no, that was a supine. What do they call it? Wait, I can't think of the slang term that's out there, where I just have them turn their knee. The hip and knee is flexed on the top. Okay. And I just have them turn their knee up, which is really, it's a combination of hip abduction and hip lateral rotation.
Oh, okay.
And the reason...
And they're supine.
No, they're on their side now.
Like a clam.
Gotcha, okay.
Not the clam, that's it.
Yeah. Yep.
You know, all of this sounds like you're either getting ready to eat or exterminate something. But so, and why do we do that for? I want to see, does the pelvis rotate? Because if the pelvis rotates, again, that's another issue, that the back is moving too readily. It's become the path of least resistance, and the hip doesn't move as well. So, I wouldn't with most back patients, but a little bit to get to your question before, is that I might spend time, if this has they've got a hip problem and the gluteus medius is not working well, I would have them work on trying to activate the gluteus medius. I want to feel it work. I want to see that. And I always tell patients, I don't care how far you don't go. I care how you get there.
Mm.
And so I just want to see that see the muscle contract and see just hip lateral rotation, abduction, rather than the pelvis rotating. What I learned too late is that's not a good way to strengthen the gluteus medius, because the gluteus medius works primarily eccentrically rather than concentrically. And there's a paper by Reeves that kind of show if you strengthen concentrically, you don't get stronger eccentrically. And if you strengthen eccentrically, you don't get stronger concentrically. So the gluteus medius is one of the muscles that really works much more eccentrically. And we'll talk a little bit about eccentric versus concentric, because that's another big issue. So then I have them do abduction. And if with the leg extended, the knees extended, the hips extended, and what do I want to see? Do they do a lateral pelvic tilt, or do they move in the hip joint? Does it hurt? Stop the tilt if it hurts. Do they tilt on the way up and on the way back? But again, it's giving you indications of how readily they're moving in the back or not, and how well their hip control is.
So it sounds like, would you subscribe to the idea that the joint by joint model of, stable joints and mobile joints and alternate pattern is something that you're looking at with an assessment?
I don't know that.
Oh, so joint by joint, I think it was Cook, Greg Cook.
And Boyle.
And Boyle. But it's basically the idea that the majority of chronic injury occurs in stable joints that were forced to become mobile. And so like the low back, the knee, the stable joints that are taking up the slack for something that's too stiff.
If you say the knee is a stable joint, I don't know why it flexes and extends.
Right.
in
yeah,
rotation,
it's not in
rotation.
Yeah, I guess like the idea.
Yeah, but I just hate the generalizations. I mean, the lack of specificity, and like making a general statement like everything's going to fall into places. I don't know why.
Yeah.
So I'm looking for the. I think that I think it all begins with a micro instability. Now I don't have super evidence, a little bit of evidence for that, and then it becomes the path of least resistance for the reasons that we're talking about, and then it moves too readily, and it becomes micro trauma, and it becomes macro trauma. So I in many ways, I'm on the other side of manual therapists who are trying to get joints to move. I'm trying to stop them from moving because that's what hurts. In some ways, I can kind of understand a little bit of the rationale in days of old, because if something's moving too much in one direction, it probably isn't moving so well in another direction.
Right.
But the fly in the ointment for me is it then has to move as readily as it's moving in the bad direction. In other words, if it takes both hands and both feet to get it to move, it's not going to go in that direction more readily than it's going in the bad direction.
Yeah.
And the other thing is, you got to ask the question of why did it get that way and what's going to happen to keep it from getting that way again. And mobilizing doesn't address either one of those issues.
So go ahead, Smitty. I have something that's going to take us away from this. So go ahead.
Oh, so could you explain a little bit? I thought it was kind of brilliant when you talk about.
Well, that's nice.
When you talk about stiffness, you liken it to springs of different tension. And you've also mentioned trying to prevent things that are in pain from moving. In your example where you're trying to create more stiffness of the abdominals versus maybe the stiffness of the quads to allow the pelvis to be more of a neutral orientation, what exercises do you favor for that? Do you favor just plank variations, or
no?
Okay.
I just think too, and I wish that I just blanked on his name, the Canadian guy,
Miguel.
Thank you. I don't know why, but I believe 100% that the reason why he got the outcomes that he got is because they did all the studies on people that have good abdominals. If you have somebody that comes in and they've got an abdomen that won't quit, and you give them a plank, it's going to still not quit when you finish. It's like we were talking about before, if you've already built in a pattern of response, it's going to respond. So no, I would never give people planks. Plus, the muscles, I'm not saying that they're bad, except they can cause shoulder problems because the scapula learns to stay still because you're fixing it on the spine. On the thorax. But what the muscle you need if the hip flexors are pulling on it is the external obliques. Now, what's tricky about that is that, do you know, like the big difference in the function of the external obliques versus the internal obliques?
One is ipsilateral and one's
No.
contralateral.
No. They're both contralateral. I mean, they're both, when you control rotation, you're using the external obliques on one side and the internal obliques on the other for rotation.
Yes.
But the action of the internal obliques, in fact, Florence Kendall used to call them upper abdominals, and the external obliques were called lower abdominals, not because one sitting down low and one sits up high, but the internal obliques curl the upper body. The external obliques do a posterior pelvic tilt. The rectus abdominis does both because it's attached to the sternum and the symphysis pubis.
Right.
So the tricky part to answer your question is the external obliques are what needs to work better because they do the posterior tilt. But the way you get them to work better is to move your lower extremities. And guess what that involves is hip flexion. So you have this balance of, that's why I wouldn't send somebody like that off to a Pilates class because all they're doing is learning to use their hip flexors so much more. And then if they have big thighs, it's going to be even worse because the muscles are so heavy that you've got to really use your hip flexors, and then they don't know how to turn them off. And then that makes your hip pop. So it's a matter, one, of having them probably slide the legs down while they maintain a pelvic tilt. And you got to be sure they're not holding their breath, but you can actually feel the contraction of the external obliques. And one is making sure that they really activate them well. And they don't just brace or do something like that. That's where a little bit of Stuart and I might disagree. I'm not fond of bracing, particularly with a heart disease.
Yeah.
It's not a good problem plan. But anyway, and then after they can contract them appropriately, I like to have them they can do things where they pull down with their arms, or when they walk, you want to make sure that they're working so they're not getting a lot of pelvic rotation, etc. And even though it's a contralateral thing is even pull downs, but you got to make sure again that they're activating the muscles and not tightening the lower extremity muscles.
Do you mean lat pull downs?
Not straight down like this, but on a diagonal.
Okay.
Like
because
chop.
Yeah.
Gotcha. Yep.
Diagonal chop.
Like this.
Okay.
And just making sure that the person's really contracting them. To me, the most valuable thing that the Australians did with the transversus is get people to hold their abdomen flat when they're working their muscles. And the external obliques are muscles of exhalation. All the abdominal muscles are. So they sometimes, to get them going in the first place, you have to have them in this hook lying position and just lift one leg up and lift the other leg up, because they can't even control that. You may have to have them hold one knee to the chest and lift you. And that's going to be particularly true in women because we have bigger lower bodies and smaller upper bodies. In men, it's not as much of an issue.
So if we were to take that example of the Pilates female who has taught their hip flexors to come on more than their abdominals, and then we put them into a corrective pattern of like I'm not even sure what you would choose now, but
like leg slides or something like that.
So is the exercise itself the thing that's biasing the muscle you need to teach it to turn on and to stiffen? Or how are you, like, here's another example that comes up all the time with the glutes and the hamstrings and, like glute bridges, maybe if someone's doing
a waste of time.
Bridges in general, you're saying? Why is that?
Because it's more quadriceps. You're not putting any kind of load on the gluteal muscles.
Right.
Because they're really, you're using quads and hamstrings primarily.
What about like a hip thrust, like a barbell loaded hip thrust?
What is a hip thrust?
So it'd be like if your back is on a bench and your hips are on the floor and the barbell's across your hips. Supposedly, Brett Contreras has done a lot for popularizing these over squats to target the glutes.
Ironically, if you look in Donald Newman's book, what you'll see is that if you're doing forward bending, that the first 20, 25 degrees is the best moment arm for the gluteal muscles. So, all the things where people are like in quadruped and they take the leg out under, they're just using their hamstrings. Because if you're over 50 degrees or 90 degrees in a forward bend, believe it or not, it's adductor magnus and hamstrings that have the best moment arms. And then the other thing you want to be sure of, because this is the big, why do the glutes get weak? You know why they get weak?
I could take a guess.
Go ahead.
Would it be? I mean, I don't know if you agree with this on
I'll tell you.
with Miguel, but Miguel would call it glute amnesia, and he just says that poor glute recruitment is the predecessor to poorly recruiting and movement patterns. But I'm guessing you have something to say along the lines of not biasing the moment arm of the glutes. Is that where you're going with that?
No, it's because people are swayed back, so their line of gravity is so far behind their hip joint that they don't need them.
So you're saying that that's more common is sway back rather than,
particularly guys with big shoulders with a little bit of increase in their abdominal muscles, so they have a little bit of kyphosis, and you can see their shoulders are slightly behind their hips. That in fact, it's fun to do, because if you just have somebody do a posterior pelvic tilt and they're palpating their gluteals, they're not working. As soon as they lean forward a little bit, here they come. So I call it missing for lack of action. So I always like to point out, so they get a pimple where their buttocks ought to be.
That's this guy over here.
Okay. Well, I'll bet you anything if I saw him standing, that's what I would see.
That's really interesting. So then I guess where I'm going with that is the curiosity behind, is it then you are picking an exercise aside from the postural alignment?
Well, you can't be aside from it.
Well, I don't mean to completely take that away. I'm in full recognition that that's part of the process. Is there any biasing of the muscle recruitment based off of the exercise selection itself?
Well, what I think is the most valuable is just doing the forward bending to about 25 degrees and coming back up, making sure they're using their gluteal muscles. Because the other thing that happens is people sway when they're trying to return from forward bending, and then they're not using their gluteals either.
Sway meaning like they're using their
it's like
spinal
the pelvis sways forward. It's like they're pulling their tibias, their legs forward. So you've got this kind of motion. And so you got to really make sure that they're coming back up using the gluteals. And you want to get rid of the alignment thing, because I don't care if you do 25 exercises, if you spend all day without them working, it's a waste of time.
Yep, that makes sense. One of the questions I had was going to take in a different direction. So, okay, so one of the things that we often try to do as strength coaches is program in, one of the sayings is strength training is corrective. And obviously there's some huge caveats as you've just pointed out. And as a strength coach who's programming for Gen Pop, let's say, that there's a lot general population. Okay. So people that are not athletes, just working professionals that just want to be healthy. Not all of them have injuries. Some of them may. We try to program templates and leave room for the individual. So we're not trying to, I guess there is some line of best fit with our programming of, okay, these are some predictable patterns. If we have an office worker that, might have some relative stiffness issues. So we want to maybe implement exercises that focus more on the posterior chain to add some stiffness back there where they need it. My question is, do you have any idea of, or I guess I'm asking for advice on some predictable patterns that you've seen for Gen Pop, so not dealing with acute injury, that you could recommend as general maintenance exercises that may be able to stave off some of the really common injuries? Well,
yeah, I don't know whether you know it, but I did a problem with Tim Ferriss. Do you know who Tim Ferriss is?
Yeah. Yep.
And I actually did an exercise program, did a video with little exercises.
Oh, no way.
Yeah.
Yeah, I saw it. There's quadruped, there's
supine, there's prone. Yeah.
Yep.
Yeah.
And you demonstrated the exercise.
And I demonstrated the exercise.
Yes.
Oh, okay.
And
right.
And if somebody 86 can do, I'm 87 now, and I can still get up and down from the floor without any difficulty.
That's awesome.
But again, you need to look at these. these people as individuals, and you need to look at their alignment, because the beauty of good alignment, and that's why I'm so fortunate to be as active as I am, is because if you sway back, here come the abdominals a little bit. If you go forward, here come the back muscles. If your knees are hyperextended, you don't use your quadriceps. And if your glutes, if you sway back and your glutes aren't working, you're going to use your hamstrings. So drafting a program is getting them as close as you can to good alignment.
Brilliant. Yeah. I mean,
it's too simple.
Yeah.
It's too simple.
Yeah, that is.
I know. But that's, in fact, I love it, because when I go through an exam, I probably only need about 5 little exercises in changing the way people do their everyday activities. Sleeping position's big. You got people who lay on their side and drape their leg across their body. Their hip abductor lateral rotators are going to get weak. I mean, particularly a woman with a wide pelvis. It's, if they get all curled up, they get up and they got neck pain. Well, because they put their head in that position. It's really, I mean, that's the bottom line for everything. How do you walk? How do you sit? How do you go from sit to stand?
Do you do a lot with alignment with the shoulder blade position as well?
Of course. I mean, if I want them to move their arms without pain. Yeah.
Yeah. And I've heard, could you talk a little, just real quick? I know we're running out of time, but this is well worth it, because a lot of meatheads, I'll just say, that use that term,
guys,
strength and conditioning, people that have just been working out their whole lives have a ton of shoulder pain because they've been doing a lot of horizontal pressing.
Hold on a minute.
Yeah, that's fine.
Let me call you back. I'm on a podcast. Thanks. Sorry.
Oh, that's okay.
Oh, you're fine.
So the shoulder position for people that, like us, who have done a lot of years of lifting, and the insufficient upward rotation and things like that. Could you just talk a little bit about that?
Yeah, I'm glad you're bringing that up, because it's one of the things that to me is so important. If you're lifting a lot of weight, how many muscles do you think you're activating?
All of them.
And you know what's a problem? They don't get the message that when you're just lifting your arm up, you're not activating all the muscles. It's this training thing. And so you're in a tug of war with your own muscles, because everything's coming in at the same time. That's why the scapula can't upwardly rotate. So after people do weight training as such, they need to then detrain. I mean, just think about this catch-22. What have you done? You've hypertrophied all of your muscles, right? So they generate more tension. So you should be using less, not more, in everyday activities. Yeah, I have great pictures of a guy. He was lifting 400 pounds. Well, all was funny because he had pain in his AC joint, acromioclavicular, and they diagnosed this as tendonitis. And I racked my brain to think of one tendon that attaches to the AC joint. But anyway, it was too stupid. And just as you're describing, he lifts his arms up, scapula doesn't upwardly rotate. He gets pain here, can't go the whole way. So I had him going like this. And 6 weeks later, his arms went up. No pain. You got it, and it's good that you're looking and you're seeing the scapula isn't upwardly rotating. Do you think somebody like that needs more strength?
Right.
That's shot. It's too stupid, isn't it?
Yeah.
To think you're going to build up a muscle to make it happen. You got to build down the muscles so that they don't activate them so much. Everybody, when they finish this big time weight training, needs to practice. And I like just fingers towards the ceiling. Easy, easy, easy.
Wow.
You see them walking with really stiff gait because everything's coming on at the wrong time.
Wow.
That blew my mind.
That's a great point.
That's such a fantastic point. There's this quote I always talk about as far as when you're thinking of longevity. There's this strength coach out of West Side in Ohio, and he said that a lot of lifters or strength guys, people who train in the gym a lot, one of their biggest detriments is not restoring range of motion after they have a training session. And because what we've talked about this whole episode is the stiffness from strength training, and that stiffness is that foundation of removing or eliminating full range of motion as time goes on. So restoring range of motion after the training session is so critical, because you're
I'll just interject just enough so you realize that part of it is, yes, the muscles are stiffer, and it'll vary in different people. Some people, if you're Asian or something, you're not going to get as stiff. If you're from a Nordic country, you'll get stiffer because there's all kinds of differences in the collagen. That's why you need to passively move somebody. And the other thing, when you passively move them after all of that, you need to find out how well they can relax their muscles, because part of what's going on, and that's the point I'm trying to make, is they now have a lower threshold for activation. They've trained their body. Here we go. All of you. And that's going to still do it when they don't have a weight in their hand.
Wow.
Are you clear about that?
Yeah,
so you've got to
that
differentiate
makes total sense.
What's really passive, and what's unconscious activation. I just had such a funny experience with, it was a while ago. What is that sport where you put yourself in a cage and you try to hit somebody?
MMA?
MMA, that's it.
Oh,
MMA,
okay.
You got it.
Yep.
Number one, what are you doing in a cage trying to hit somebody? But it already says there's a problem.
Yeah.
But anyway, it was actually one of our students, and it was so interesting because when he was prone and I just tried to flex his knee, I practically needed a lift to do it. It was so stiff. And then I finally tumbled to the fact that he was used to doing MMA. So he would go in, and anytime he was going to do an exercise, he just tightened up everything. And all I had to do was to get him to really relax, and then I could easily bend his knee. So That's what I'm saying is you some people, it happens bad, other people not so much. So you've got to make that determination. But it's not just the properties of muscle. It'll also be what they've trained themselves to do.
Well, that makes so much sense, because one of my first experiences doing an assessment was on AJ Roberts, who has been on this podcast, world record powerlifter, squats over 1,000 pounds. And I remember trying to lift his knee off the ground, and it was the same experience. It wasn't just the fact that his leg was the size of a tree, but it felt like it was just so resistant to hip extension. And that makes so much sense.
What position was he in? He was supine?
Prone. He was prone,
and
I was
you were trying to flex his knee. Don't lift his hip, because that's going to be really hard. But just
blow
flex
my back out.
Just try to passively flex his knee.
Yeah.
How do you? Go ahead.
I just want to give you another little piece of advice.
Yeah.
And it has to do with the hamstrings, because if you have somebody sitting up without a back support, and you try to straighten their knee out to assess the hamstring length, do you do that or not?
No.
Oh, you don't do that. Well, never mind that.
But I'd like to hear what you were going with that.
Okay. Well, that's so interesting. Then how do you know that the hamstrings are working all the time? Anyway, is that you have to be sure that you have somebody sitting with a back support, because if they're sitting up and you try to straighten their knee out, they'll be activating their hamstrings, because they're hooked in. If they're sitting up there, they have to use their hip flexors. Hip flexors pull on the pelvis, and the hamstrings say, no, you can't. Let's keep you from going. And so they're getting this little bit of hamstring contraction. And therefore, it'll make it seem like it's short or stiff. And then if you sit them in a chair and do it, it's not an issue.
I see. So they're sitting off of the edge of a bench or a
plinth. They're just sitting on a bed, free, no back support. Put them in a chair, and you'll have a different. Same thing. You can't make an assumption with forward bending that the hamstrings are short, because they're using those to go down.
Yes. Yeah.
And so they don't turn them off well.
Yeah, that makes total sense.
Yeah. You mentioned you worked with the MMA fighter to get him to relax. How did you do that? Is it with the breathe?
No, just jostle the leg around, let go.
Oh, okay.
Okay.
Well, and here's the other thing you have to have in your heads is people don't know anything except what they know. Meaning, if you are used to having all of your muscles contracting, you don't know another state. You don't know that they're contracting all the time. They have to be taught, because you only know what's familiar, not what's right. We don't have an internal sensing machine that says, oop, on target, oop, off target.
Yeah.
So that's a really big factor to realize. You've got to teach them what's going on.
Right. And is that part of the corrective strategy for you?
Absolutely.
Are you doing any down regulation of the hypertonicity?
In fact, we were talking a little bit about this. What's fascinating to me is, after you do an active contraction, the way it goes back is by eccentric. If you flex your elbow, It goes back. Well, there aren't the mechanisms to speed up the relaxation of an eccentric contraction. So the more you've activated something. So what you'll see in some people, I'll give you the example, is they flex their elbow and their elbow flexors are so stiff that they put it down. They use the triceps to put it down. And if you ask them to flex their elbow and let it fall down, it goes so slowly because that spring is so stiff. That's why they've learned to use the antagonist to put it down.
So the elongation is like actually preventing the joint to return.
And that's another thing in the people that have lifted a lot of weights that makes it so difficult.
Yeah, I mean, if you think about wrestlers and their stature of, when they walk, you can see that they're stuck in elbow flexion, and wow.
Right.
Yeah. So could you just give a real quick, I don't want to overextend our time here, but could you give an example of maybe something that you would do aside from just asking them to relax? Like, let's say it is, an elbow flexor. Are you doing like some type of SMR, myofascial release, or what are you doing to try to get that muscle to relax?
Teaching them,
cueing them.
And you also have to, the other thing is, what is their exercise program? Are they only working this? Are they working from full extension after they do it? Are they working from already elbow flexed and they're only working in a range that's keeping the elbow flexed?
Yeah.
And then it's what we talked about before. You want to do a whole bunch of these, then you better get up and let it learn to fall down. You got to let it learn to fall down.
Wow, man. You made this a lot more simple than I think a lot of people make it.
I'm all for simple. That's hard enough.
We're firing on all cylinders here, just trying to keep up.
To me, it's so important that people recognize that one size doesn't fit all.
Yes.
And I think it's important to recognize that in some ways, if you just really use your background in anatomy and kinesiology and get rid of these fancy terms that don't, so many people use different terms for the same thing. And then it just gets to be messy.
Yeah.
Because you're busy figuring out what does Stewart mean? What is, whatever Gray Cook is saying. They're probably in many ways saying the same thing.
Yeah.
But you don't know it because the terminology isn't consistent.
Yeah.
Isn't the same. And then it's just, hang on to some generalities.
I love it. Well, is there any final message you would like to shout from the rooftops to the strength and conditioning industry as you have their ear? Any final words of wisdom?
And I think we've hit on everything. And
I think so. That was a great point. The thing that not to interrupt you, the common theme on this podcast is the answer is it always depends. And we do some Q&A episodes, and it's almost a cliche at this point of the answer always depends. And part of the podcast is try to elucidate some of those things and some of the factors that contribute to that. And I think that you've done a spectacular job at that. And, it's fun. I was saying to Smitty, one of the quotes that I had written down here was one that you mentioned earlier was, I don't care how far you go, I care how you get there. And I love that. Almost as an analogy for my perception of you in your industry, because I don't know if you have any social media now, but a lot of the industry is shaped by the algorithm. Whatever does best on social media is what is pervasive. Yeah. And it's what is in the hands of new coaches. And you can see it in the industry, especially in the strength and conditioning field. And I love that you stuck to your guns and you really helped put things that work into the hands of those who need it most, including the clients of myself and my coaches have all used a lot of your stuff. And I'm excited to get this podcast out because I think it's going to help a lot of people.
I always follow up that I don't care how far it's not what you do, it's how you do it. That's another one.
Yeah.
And I always say I skied, but nobody wanted me in the Olympics. It's not what you do, it's how you do it.
Yeah. Shirley, we'd love to have you on for part 2 because I have probably 10 other questions here. But I did want to mention my favorite quote is the body moves in the path of least resistance. And that's something I always remembered.
It's the joint, and yes. And the other thing that is this thing we talked about is the body wants to be efficient. It minimizes its energy expenditure and it's going to use what it's used to using and not use the other things. That's why this whole idea that Why do normally innervated muscles get weak? What is it that they're not doing? What have you overactivated that's bypassing its synergist or its friends?
So it chooses energy efficiency over biomechanical efficiency.
Absolutely. I mean, it will let you destroy yourself in using what works best.
Wow. Beautiful. Well, I think those are great points to end on.
Yep.
Would you like us to send the listener to a website, or do you have any
I don't
landing?
have any websites.
All right, I love it. That's why you're doing so well in life. Is stay off of social media.
We'll send them to your books.
Yeah.
Yeah, we're working on trying to get a new edition out, because you know how old that edition is. I was lucky that they had print at the time I wrote that.
Yeah, well, that we'll definitely post links to this book, because if anyone's listening and they don't have this on their bookshelf, as you can see, mine's falling apart. This is a book that I referenced.
So can I take 2 minutes of your time?
Absolutely.
Because we're redoing the book. What have you found the most useful?
Honestly, probably just the fact that it's simpler than it needs to be. I think a lot of the people that I shadowed early on were being in the strength and conditioning industry. I think there's an allure to what physical therapists are doing. And like you said, I think it was almost too disconnected from the things that I was seeing work. And I think it's just almost on accident that, we were helping people recreate their movement patterns. And it wasn't so much that I knew exactly why it was working. And then I felt like a lot of the physical therapists were not really seeing progress. And so I think the categorization of the pain, like just knowing that if they flex forward and that's causing them pain, I don't need all of this background and pathophysiology, and I don't need to know anything about discs and discectomies. All I need to know is we need to figure out how to recreate that movement. And that was a game changer for me. Having this as an early coach really shaped the trajectory of my career, because I've spent a lot of time looking more into assessment and corrective exercise than I originally ever thought I would. So yeah, I think I don't know what you're going to say.
I was just going to say it almost feels like maybe the best route is 2 different versions, one for the strength coach.
I was just going to say the same thing.
And one for the PTs that has all the background information, all the technical jargon that they would appreciate, but then one for the strength coach who needs the application. What I like is the movement impairment, where the pain is, and then the path forward. Step 1 is this: assessing the length of the quads, the stiffness of the abs. Have a stepwise progression for each movement impairment. I think that would be invaluable resource. But it does feel like when you're talking to us, I got a lot more out of it, just because the way your explanations are so simple, and it's so methodical and very logical, if you will. I think
it's empowering to the strength.
It's empowering, yes, of course. And I would love a resource that had that stepwise, methodical, like path forward out of pain. But there, I'm sure the PTs would appreciate more of the in-depth, explanation.
Did you use the exercises in the back or the examination stuff at all? No.
Yeah, we've both been through plenty of
because
that.
In some ways I was thinking about leaving it out, but you found it useful.
Yeah.
No, I think it's great.
Yeah. I think a lot of strength coaches or people in the fitness industry are more visual learners. So having like the exercise index and knowing the right execution and the right sequence of the execution is probably it's the knowledge, but also the application, the path forward, I think is really empowering.
I'm actually trying to do more clinical application and leaving out some of the basic science more, because
that I think that would be fun. I mean, I enjoyed it, and I have my degree in exercise science, so it was a nice lead into your application with the exercise science. But I don't know, I feel like, not to be disparaging, but I do feel like people care less and less about that, and they just want the tangibles, the things they can immediately put into practice.
Sounds like society.
Yes. Yeah. Yep. I've officially joined the salty person who, the crowd that just complains, but I get it. So, but yeah, I mean, any questions you have, and I can put it out to some other peers in the industry if you want any feedback on.
I do. It would be most useful if you have suggestions about, like you've just been giving me, about what works better. And
yeah. And you have our email too. So if you want to reach out or.
Absolutely.
Absolutely would love to help.
Okay. Well, that's very kind.
Well, Shirley, thank you so much for your
My
time.
pleasure.
This has been amazing. I'm going to go back through and listen to
Yeah,
it 10
absolutely.
more times and take some notes.
Really, thank you so much.
My pleasure. Take care, fellas.